Thank you very much. So thanks very much for having me today to have a discussion on HIV and aging. So I'm provided with this topic, so I believe I'm charged with the mission to make a case for the need of geriatric care for our aging patients. So these are my disclosures. And so for the next 25 minutes, first of all, we'll look at some biological processes of aging in the population of people living with HIV and how these processes are manifested clinically. That's just what we are actually seeing in the clinic, or on the other hand, what we actually should be looking for in the clinic setting. Next, we will look at whether aging well is possible, and if so, how can this be done? And lastly, of course, how can geriatric care be actually delivered in our clinic setting? So, first of all, we should be clear that our chronological age, meaning how old we are on the calendar year, actually only partially contributes to actually how old we are. By this, we usually refer to what we call biological aging. So as we age, most of us do have a reducing ability in maintaining the homeostasis at cellular and molecular levels. And clinically, this will be manifested as malfunctions in various physiological systems. And putting it graphically, if we look at the graph on the left, as we age, these biological aging processes were set in. The blue line and the blue shades in the diagram represents the normal population. For people with HIV, once they are infected, usually these aging processes will be accelerated. However, with effective treatment, this will actually be partially reversed. And in people with HIV, if we look at studies using various biological markers of aging, we would see that can be manifested as a weakened immune systems, immunosenescence, mitochondrial dysfunction, and also epigenetic changes. So, studies looking at using these biomarkers did show that use of effective antiretroviral therapy do have a role in partially attenuating this biological aging process. So, for example, the study on the left, they use different epigenetic clocks, so some markers of biological aging. And the bars, the dark red bars on the left side of each of those boxes represent treatment-naive people. And the light red one on the right side of each box represent people without HIV infection. So you can see that in general, people not treated with antiretroviral treatment do have an older biological age. And after around 3 years of treatment, represented by the pinkish box in the middle, they sort of are brought younger by the treatment, but still not approaching that of the uninfected population. Another study on the right used sophisticated MRI techniques looking at aging in the brain. And the green line in the middle represents the normal population, and farther away from the line represent a wider age gap, brain age gap. So those who are treatment naive, shown by the red line, has a wider gap compared to those who are on treatment, as shown by the orange line here. So as mentioned, with biological aging, it's not surprising that actually different parts of our body, different physiological systems are affected and will be manifested clinically. This study very nicely showed that in a cohort of people with either HIV infection or methamphetamine use, they look at the telomere length, which is another marker of biological aging. The shorter the telomere, the older the biological age. And it nicely shows that the telomere length actually correlates very well with various clinical markers, including inflammation, endothelial dysfunction, cognitive function, and mood, depression, and frailty, cardiovascular risk, etc., etc. Therefore, it won't be surprising that people who do age more prematurely might have impact on their clinical manifestations. So, and of course, one of the very important manifestations would be the development of these age-related comorbidities. So things like diabetes, hypertension, chronic kidney disease, all these types of chronic diseases, which we do expect to have higher prevalence or incidence as one gets older. And so there are actually multiple studies comparing people with and without HIV from various countries. The one shown on the left here is from Amsterdam, just one of these many examples. And they show that people with HIV on average have the same number of comorbidities compared to people without HIV around 10 years older. And the study on the right looked at the subclinical atherosclerosis by measuring the carotid intermediate thickness, a study done in China. And again, they compare people with and without HIV, represented by the red and the blue bars there. And you can see that especially in the younger age group, people with HIV do have a significantly higher risk of these chronic illnesses. Therefore, we do expect that many of our patients probably would have a higher incidence as well as earlier onset of these comorbidities. And what's interesting is that these comorbidities don't just happen randomly. So there are studies showing clustering patterns of these different kinds of comorbidity. So we usually define multimorbidity by the presence of 2 or more comorbidities, and it's actually not uncommon among people with HIV. And if you look at these clustering of different patterns, you can imagine that probably the diseases within each of these clusters share some common risk factors. Therefore, it also means that if you do have an individual having a single comorbidity, they would have a higher risk of another comorbidity within that cluster. And this brings us to this concept of geriatric syndrome. So multimorbidity is a typical example of geriatric syndromes, and there are many others, such as a very closely related but a distinct concept of polypharmacy, cognitive impairment, incontinence, which can happen in both men and women, frailty, sarcopenia, and falls. So these are just some of the examples of what we call geriatric syndromes. And what do we mean by that? Basically, it's a presentation with a symptom or a constellation of symptoms in generally which are more common in older people. And by multifactorial, it doesn't just mean that as a syndrome, it has multiple risk factors. But for an individual having this a particular syndrome, there are actually multiple factors within this individual contributing to the increased risk of having this syndrome. And of course, it could involve multiple systems. So as an example, we might be familiar with Alzheimer's disease as a distinct disease entity with a very distinctive pathogenesis, with accumulation of some beta amyloid plaques in certain areas of the brain. But a person with cognitive impairment is a different story. It could be due to multiple risk factors within that individual. Substance use, mood disorders, which we have just heard. It could be due to drugs. It could be due to other pathologic processes inside the brain. So when we assess the patient with these geriatric symptoms, we have to adopt a more holistic approach. So some of the examples. Polypharmacy, the definitions sometimes vary between different studies. Most studies in people with HIV define polypharmacy by the presence of 5 or more co-medications other than antiretroviral drugs. So most studies did show that people with HIV have a higher prevalence of polypharmacy than those without the infection. And some common drugs are those used for cardiovascular and gastrointestinal diseases. And not surprisingly, the more drugs you have, more problems. So one of those are drug interactions, and it can occur among antiretroviral drugs, and of course between antiviral drugs and the other co-medications. So even with the increased use of integrase inhibitors, which have already spared us a lot of headaches from drug interactions between antiretrovirals and other medications, we are still not immune from these problems of interactions. And of course, adherence would be an issue, especially in people with polypharmacy. Well, interestingly, people who are older actually are more adherent to the antiretroviral. And I guess many of us would have shared this from our own experience. So usually the younger patients are those with problems with adherence. However, for the older people, they do have issues with adhering to the non-antiretroviral co-medications. I do have a couple of patients who have no problem accepting the HIV status and taking the antiretrovirals, but can not accept the diagnosis of hypertension or diabetes and really refuse to take these medications. So as our patients get older, these are some of the issues that might set in. And of course, adverse drug reactions. Again, the more the drugs, the more side effects. So examples, anticholinergic side effects are very common among the co-medications. And something we sometimes quite neglect is the treatment burden. So we often talk about the pill burden and how much effort our patients are putting into when adhering to the antiretroviral therapy. But since these treatments are so easy to take now, one pill once a day, sometimes we might neglect the effort that they also have to make in getting all the other non-antiretroviral co-medications, taking them adherently and according to instructions. So falls, again, is a very classical example of geriatric syndrome. So I'm not sure if any of you would include a question of whether you have a recent fall during your routine clinic visit. So if you haven't done so, I very much encourage you to try next week when you go back to your clinic. I have been starting to ask my patients, and in my cohort, the average age was around 50-something. And I'm actually quite surprised that when I review the data, almost 20% of them had a fall in the last 12 months. So I actually don't expect 1 out of 5 of my patients with an average age of 50-something having a fall. And similar studies around the world, for example, the one quoted here, a very recent study from the US, 21% of those aged 50 and above have serious falls. So this could be actually quite a serious problem. And as mentioned, for any other geriatric syndrome, when the patient did complain of a fall, we don't go straight into doing a lower limb neurologic examination. Rather, we should go through all the list of factors listed here in this slide. They could be due to medication side effects. They could be due to pain syndrome in their knee joints, and so on and so forth. So this is what we usually mean by a holistic approach in assessing these older persons when they do encounter new symptoms and problems. And frailty, of course, is a classic geriatric syndrome, and there have been quite a number of studies in the population with HIV. Frailty usually is defined by a decline in physical and also functional reserve. And the greatest problem is that it makes a person more vulnerable to the usual life stresses, which normally would not cause any problems in an otherwise non-frail individual. So again, most studies did show that people with HIV have a higher risk of frailty. And because of these negative health impacts, they are prone to have more cognitive decline, falls, disability, institutionalization, etc., and other negative health outcomes. And in terms of assessment in the clinic, there are actually a lot of tools which we can use to measure frailty. And so allow me some commercial time here. There will be a capacity building session on the morning of the 9th of June, Friday. Okay, so welcome to join the session, and we'll talk more about measuring frailty. And of course, some people are more prone to having frailty. Of course, those who are diagnosed late have a very low nadir CD4 count, starting treatment late, other comorbidities, substance use, etc. So these are the particular type of patients that probably we would like to screen for frailty. The most classical definition of frailty is defined by the Fried phenotype. So there are 5 categories, including weight loss, exhaustion, physical inactivity, the gait speed, and also the hand grip strength. So if a person, and there are some well-defined criteria listed here, and if a person fulfills 3 among these 5 categories, then this patient is categorized as being frail. If they do have 1 or 2 criteria met, then they are classified as being pre-frail. So, and interestingly, frailty is actually a dynamic state, meaning that a person's frailty status can change over time. And this is a study from the Amsterdam cohort. And at baseline, people with HIV, unsurprisingly, are having a high prevalence of frailty and pre-frailty, as shown at the bottom of the slide. 11 and 50% of those are frail and pre-frail. However, over a period of 2 years, although slightly more people with HIV at baseline who are robust did progress to pre-frailty. On the other hand, if you look at this picture on the right-hand side, those who are frail at baseline, actually more of them in the group people with HIV infection actually sort of reverted back to pre-frailty and robust state. So this is actually good news for our patients, meaning that it's a dynamic state, it can be reversed, and with suitable intervention, we actually can prevent or treat frailty. So a very related concept, sarcopenia. So sarcopenia is not just the loss of muscle mass, but rather we have to include the assessment of muscle strength and physical performance. So there are groups in Europe and also in Asia sitting together to have a consensus definition of sarcopenia. So the definition I've shown here on this slide comes from the Asian group looking into sarcopenia, and they have a revised criteria definition in 2019 as shown here. So we usually measure muscle mass, the appendicular muscle mass, meaning all the muscle mass or lean mass, including all 4 limbs. And the sort of the gold standard is to measure by DEXA scan, but they also have a criteria using bioelectrical impedance analysis. And for muscle strength, it's defined by a weak hand grip strength, and they have cutoffs for men and women as well. And for physical performance, it can be measured by gait speed, chair stand tests, or other physical performance tests. So in Hong Kong, we have looked in our cohort of around 150 patients, average age around 60 years old, looking at the prevalence of sarcopenia and also the impact of sarcopenia on the quality of life. And again, not surprisingly, a high prevalence of them have sarcopenia. So around a quarter of our patients do have sarcopenia as defined by the definition as shown in the last slide. But more importantly, those with sarcopenia or severe sarcopenia do have worse quality of life, as shown by an impairment in the mobility, in their usual activities, and also signs of disability as well, as shown by worsened instrumental activities of daily living. So with all these issues that can potentially come up in our patients, is aging well still possible? And if so, how can we implement that in our clinic? So what we have talked about the whole day, the first 3 cascade, the treatment goals in our cascade, are definitely the key and most important strategies in maintaining a healthy general well-being in our patients. So diagnose early, test early, treat early, and all these would be very important in introducing early viral suppression and also avoiding the possible potential comorbidities, complications in the long run. What I would like to point out is that, of course, the young populations might be a key population arising in our region, but still don't remember that we do have older patients who are having a new infection when they age about 50, which is not surprising. And very often, at least in Hong Kong, those are the patients who are the ones who present late, usually with ACE diagnosis presenting to hospital really late. So always think about HIV as well when we encounter older patients. And in terms of therapeutics for aging. So unfortunately, the ones listed here in terms of anti-aging therapy are more experimental than practically can be used in our clinic. Otherwise, I guess every one of us have already been using these drugs. However, I would still like to highlight the study on the left as shown here, the statins. So we do believe that statins, other than lowering the cholesterol, do have anti-inflammatory effect as well. And the Reprieve trial is a very large trial that have been running for years, and they have just released the results showing that the use of statins in people who have a low to moderate level of cardiovascular risk. So usually these patients won't be started on statin, but if they are started on statin, it's shown that they actually do have a 35% reduction in the risk of heart-related diseases. So of course it's not a classical form of anti-aging therapy, but again it's some form of therapeutics that might have a preventive role in terms of comorbidities and aging. So for comorbidities, prevention, of course, is better than cure. So again, preventions like immunizations, lifestyle intervention early on before even the comorbidity sets in. And again, same as HIV, early diagnosis, screening, testing in the appropriate patients and setting would also be beneficial in the long run. And I've been talking about polypharmacy, so medicine optimization is a very important role in our clinic. There are quite a number of strategies using de-prescribing and also regimen simplification to minimize all the issues that I've been talking about on polypharmacy. And many a times our pharmacists will have a very key role in guiding these programs and also to minimize the use of inappropriate treatment. And exercise nutrition cannot be stated in terms of their importance and very much neglected in many clinic settings, but are very, very important in the prevention and treatment of things like frailty and sarcopenia. So, particularly for nutrition, it's not just what the choice of food, but in older people, sometimes there's the other problems like things like oral health, swallowing problems that might have to be taken into consideration as well when we are talking about nutrition. So in the last few minutes, how actually we can be delivering these form of geriatric care in our clinics. So I'm sure you are all very well aware of the challenges in implementing geriatric care. So for the people with HIV, we have gone through how complex the situations can be when they do present with aging-related issues, and we are all very focused on disease-focused care, on how to maintain a suppressed viral load and giving antiretroviral treatment for HIV. But when the patient gets older, probably we have to implement more holistic and person-centered care. And the stigma associated with HIV and ageism, the intersection of these two actually can be very traumatic. And remember, many of our patients who do develop these age-related issues are not really that old chronologically. So they might be in their 50s or early 60s, who are not actually very prepared to face these problems of aging. So these are something we should be considering as well. And many patients are actually under the care of HIV healthcare providers or the GPs. And many a times, we are not the best person on those who are not having expertise, experience in these aging-related issues. And at the same time, the geriatricians, who should be the best persons delivering care for patients with frailty, sarcopenia, falls, might not be too comfortable looking at people with HIV just because they are not actually familiar with the disease and also with the therapeutic treatment. And also, as mentioned, they might be comfortable taking care of people in their 70s, 80s, but probably not those in their 50s and 60s. And having all these challenges, I guess there's no a single right model that can be implemented in each and every clinic. However, what we should be focusing on is try to provide integrated and person-centered care with a well-defined goal of promoting healthy aging for each and every of our patients, and by preserving their functional abilities, not just treating their viral load, which is of course important, but we have to look broader than that. And of course, we are not introducing multidisciplinary team in every clinic, which is of course perfect, ideal, but not feasible. However, in our approach in treating our patients or delivering care, we do have to consider a more multidimensional aspect, both in terms of diagnosis, treatment, and also involvement of community partners, which we have been sharing for this meeting. And again, I guess the best approach for each clinic is the one that do address the local needs and also take into consideration the availability of local resources. And with that, we try to provide a personalized care for our patients. And the second last slide here, there are some published data on the existing care models in delivering geriatric care in HIV centers around the world. So they can be sort of categorized into a few approaches. For example, people are mainly treated, managed by a primary care provider, usually the HIV physician, and referred to geriatricians when they do encounter problems related to aging. In some centers, they do have a combined HIV geriatric clinic where they do provide multidisciplinary care with HIV physicians, geriatricians, neurologists, cardiologists, physiotherapists, nutritionists, et cetera, providing a sort of a one-stop service at a clinic. And in some centers, a single physician or single team of physicians receive dual training in both HIV and also geriatrics care. So as mentioned, I don't think there is a sort of an ideal approach for everyone. So what I'm trying to do in the last slide is just to share what we are doing in our clinic. And it's, to start off, we are a comorbidities clinic at the Prince of Wales Hospital in Hong Kong, and we receive referrals from other HIV clinics who do not have the support for management of comorbidities. So in the very beginning when we started, we focused on these various age-related comorbidities. We screened for cardiovascular diseases, fatty liver, fibrosis, osteoporosis, we do DEXA scans, et cetera, et cetera. So we focus on these individual diseases. Then with time, when we noted that aging-related issues are becoming an issue both from the published literature and also from our own patients, we started to sort of switch our focus to include more age-related management as well. And with that, of course, we try to incorporate everything with our existing systems, but we did try to get extra resources in terms of research fundings and donations. And also we rely heavily on technology. We use electronic devices and platforms to collect data and also perform all the assessments. And we try to deliver a comprehensive assessment, including both the physical, mental health issues, the social issues, cognitive assessments, quality of life, etc., in our routine assessments for our patients. And in terms of the multidisciplinary nature of our service, is by no means very structured. It cannot be categorized as one of those listed in the last slide. But we do have the privilege of a very interested neurologist who have the expertise in neurodegenerative diseases and interested in HIV medicine as well. And she provided care for patients with things like cognitive impairment or other neurological deficits. And we did joint sessions together for our patients. And our geriatrics team in our hospital actually has a very good expertise in doing research in aging, and therefore it's difficult to ask them to provide direct care for our patients. However, they do provide training for our staff from our own team, and therefore we can start to provide those assessments for our patients after receiving their training, and also we have collaborative projects in terms of research. And in terms of partnership with communities, in Hong Kong, we do have the privilege of having some CBOs with the access to physiotherapists and also nursing services who are interested or experienced in taking care of patients with frailty, sarcopenia, and other geriatric issues. So we often refer our patients to them to tackle all these geriatric-related issues. So with this, yeah. So thanks very much, and I'm happy to take questions in the next session.